It's a privilege to be here. Glad to see everybody out. I thought we were meeting in Scottsdale. That's the only place I know is North Mountain and Scottsdale. So I'm learning my way around the city. So I'm going to talk to you this morning about geriatric trauma. Again, here in Phoenix, the elderly population is high, a little bit higher than Texas, but I think it's growing everywhere, and you'll kind of see that. So nothing to disclose. This is where I work, and this is my team. And just like everybody else, we're starting to see more and more patients. We last year saw over 3,000 patient visits, trauma. We see mostly blunt, a little bit of penetrating. And like everybody else, motor vehicle collisions, motorcycles, autoped. If you notice falls used to be sort of way down here at the end. Let me see if this pointer works. But falls is now number 2, and I'm sure every trauma center is experiencing the exact same thing. So motor vehicle collisions followed by falls. Okay, so let's talk a little bit about geriatrics. So back in the 1900s, life expectancy was about 50 years. People lived to be about 50. That's changed completely. Current life expectancy is about 80 years. So from 2000 to 2010, okay, this is the number of people over 65, 35 to 40 million, okay, about 14% increase. So if you look now, 2010 to 2020, that number is increasing significantly. So this is age greater than 65, increase of 38%. And although it may drift down a little bit from 2020 to 2030, we're still talking 31% increase, and we're only talking age, people over 65 years old. So more interesting, in 2009, people over the age of 85 numbered about 5.6 million. 2010, 5.8 million, and again, this number continues to rise. Now we're talking people over the age of 85 years old. So back in 2007, the CDC kind of already had their eyes on this, noticing that injury and violence were serious threats to the health and well-being of Americans over the age of 65. You have to keep this in perspective. Most of us went into trauma to take care of young trauma patients. You know, our patient population were, car wrecks and, gun and knife club. We were not thinking at all about people over the age of 65 being the majority of our trauma patients. So what does all this mean? Well, for us it means that there's an increasing elderly population that we are all seeing as trauma centers. So geriatric trauma studies have shown that morbidity and mortality is strongly correlated with age. Trauma death rate, this is per 100,000, right? Age over 56. All age groups, the trauma death rate per 100,000, 56%. Just looking at age over 65, more than doubles, over 113% per 100,000. Again, significant. So what's different about geriatric trauma? Well, the things that we all think that we know. The elderly patients, they present a challenge because they have pre-existing health problems. They have decreased physiologic reserves. They had multiple operations in the past on blood thinners. Their injury patterns, maybe they're different. Well, they are different. They fall. Domestic abuse and some self-inflicted injury. These are things that we feel we're all comfortable with and we know. And then let's not forget the whole polypharmacy issue. All right, a lot of patients that are older are on antihypertensive, antiarrhythmics, hypoglycemic agents, antiplatelet, and anticoagulation. So pre-existing conditions, when you reach about 40, there's about a 17% chance that you will have a pre-existing condition, and this goes up. By the 60th decade, your chance of having a pre-existing condition, 40%. 70th decade, 70%, and then 80% by the time you're in your 90th decade. So it's these pre-existing conditions that make it difficult for patients to respond to the acute stress of trauma, we believe. So what happened and how did I kind of get involved in this whole thing? It started back in 2008, and we basically asked the question, should we activate a level 1 activation just if the patient's over 60, just that alone? And so we asked that question. So we queried the National Trauma Data Bank from January 1999 to 2008, looking at all patients and associated injuries. We abstracted data on patients' age and their ISS, and there were over 800,000 patients, and 21% of these patients were over the age of 60, and 60 is what we were looking at. What's the morbidity and mortality of those patients over 60? And if they're over 60, should that alone be one of our criteria to up our level of trauma activation? And so this is what we found. And this is pretty astonishing. And focus on the minor trauma. Focus on those patients who had a minor ISS from 0 to 9. If you were under 60, your morbidity was 1.5. Just being over 60, minor trauma, your morbidity goes up 5, which is statistically significant. And it all the way across the board, as your trauma goes up and your age goes up, your morbidity's up. And so it's those minor ISSs and those major, 10 to 15, that really caught our attention. Should we activate if the patient's in a trauma and they're over 60, should that be a criteria? Well, despite this great data that we looked at with the morbidity, we kind of concluded from the study that yes, there's a relationship that exists between age, pre-existing medical conditions, and poor physiologic reserve, and all this results in poor outcome. And we concluded that it's essential not to under-triage the elderly patient with minor injuries, and that we all need a high index of suspicion when it comes to our elderly patients. However, when this was presented at meetings, you could imagine the arguments back and forth from the trauma surgeons. I shouldn't have to get out of bed and come to a high-level activation just because the patient's over 60. Although they can see that even with minor injuries, they don't do as well. And so this argument sort of went around, but what do we do about these elderly patients with a minor injury? Let's say they fell and they just broke their tibia or their fibula. Should we all get up and activate? What should we do about those patients? So we sort of had this working hypothesis that we bounced around for a couple of years. And you can read this. This is one of my partners, the way he said it. And this is what I said. Basically, much more simplistic, that the trauma care given to older trauma patients should be distinctive from the care that younger trauma patients require with the exact same injury. All right? Young patient breaks their leg, shouldn't be managed the same way as a 70-year-old who broke their leg. You can't treat them the exact same and expect to have the same results. So, treating patients with isolated injuries in a setting of chronic medical problems can lead to fragmentation of care delivery. So the big question was, who's going to assume the care of these elderly patients? And there was a little bit of a feud when this first started in Dallas. Elderly patient falls, breaks their hip or breaks their femur. Trauma wants to sign off to medicine. Medicine says, well, that's a trauma. Ortho says, I'll fix the femur, but I'm done. And so you're left with who's going to take care of this patient? And it's a real question that needed to be answered. Again, people went into trauma to take care of, in our minds, the gunshot wounds, the stab wounds, the horrible car wrecks, not the elderly patient that falls and breaks their femur or breaks their leg. So we really do, it was a reasonable question. Who is going to assume the care of these patients? And so we organized, at that time we called it our G60, our Geriatric Trauma Unit. If I remember in the end, I'll tell you why we called it G60. So we organized a geriatric trauma service, and we as trauma surgeons just said, they're trauma patients, they're in a trauma, they've been traumatized, we're the trauma surgeons, we're equipped to handle this, let's keep them on our service. And I kind of spearheaded this, and it stemmed from seeing a patient who did fall with an isolated injury, and we would sign that patient off to medicine, and then we're making rounds, and we'd see the patient later in the unit on the ventilator, and we ask the question, what happened? And you get this answer, that answer, and we were seeing that more and more. So we decided, let's keep them on our team and see if we can do this different and do this better, and try to do this with some sort of a multidisciplinary approach. And so how we did it, and I'll kind of go through this a little rapidly. The biggest thing is getting people to recognize that, hey, we have a problem. So we started the discussion that there's a problem when it comes to our elderly trauma patients, that there's an increase in their morbidity and mortality when they don't get to the operating room in a timely manner. And evidence shows that they need to be in the operating room within 48 hours. They don't need to be on the floor getting their cardiac clearance and this cleared and that cleared. You need to get them to the operating room as soon as possible, or they won't do well. So we started multiple conversations. Always, when you want to make a big change in a hospital, you got to start with administration. And so you get administration to buy in, and they've got to believe there's a problem with the way we take care of our elderly trauma patients, and just help them understand that you have this issue, which we did. And then from there, get all your players involved. And so we started the dialogue between trauma surgeons, and we went to the ER physicians, and we said, how can we come up with more effective triage and get these patients to the appropriate disposition? And you can imagine that it's a little bit of a problem because, again, a lot of these patients, probably over 70%, were elderly patients that fell. So they fall, they come to the ER, it's not a trauma activation, they're worked up, and they get troponins first and EKGs, and did they have a stroke? Are they having a heart attack? Do they have a pneumonia? No, they fell and they broke their femur, and we need to get them out of the ER and get them admitted, and we need to move a little more effectively. And then the other key players we identified, orthopedic surgeons, internal medicine, cardiology, anesthesia, and kind of got them all to be on board. Hey, we have a problem with our elderly patients. We're going to stop fighting about it. The trauma team will assume the responsibility. They'll be on our service. We want to expedite their care, get them out of the ER, get them worked up, and get them to the operating room if they need to be. And so, again, we had to get ortho involved and convince them. I know you have busy schedules, but if we call you about a patient that's a G60, over the age of 60, can we kind of prioritize their case? Put that case first and put the 20-year-old femur fracture second instead of, well, I'm going to wait till medicine clears them, so I'm not even going to put them on my schedule till 3 days from now, because that's about how long it's going to take to get them medically cleared. Or they're on Coumadin, and I'm going to give them, give the medicine guys 4 or 5 days to get their INR where I need it to be, so I didn't put them on my schedule till next Friday. So we got them to say, no, let's not do that anymore. Let's prioritize. Let's get those elderly patients on the schedule first. Got everybody involved, got cardiology. If you want to clear them, if they need cardiac clearance, do it right away. And then we got every specialty involved, and you guys know how we do this. Just have pizza and lunch, and they will come to the meetings. And so we've got everybody to come, and we probably met every other week for a while. Physical therapy, social workers, case managers, respiratory, pharmacy. You'd be amazed the stories I heard from physical therapists. Why didn't you get this patient out of bed and walk them? They will walk in a 25-year-old's room and say, hey, you need to get up. No, my leg hurts. I just had surgery. Get up. You need to get up. They'll walk in a 70-year-old lady's room. Ma'am, I'm your physical therapist. I need to get you up. No, get out of here. Okay, yes, ma'am. I'll see you tomorrow. So we had to get them to understand, let's flip that. If you're going to let somebody lay, don't let it be the 70-year-old patient. So it was a real culture change, and I was shocked to hear that, but I knew that was true because I would have a hard time kind of telling the 70-year-old what they have to do. So we had to help them understand that it's in their best interest that we expedite things. So we established this G60 in our hospital. We found an area in the hospital because, again, we got buy-in from administration, so they were good with this. And then I told them we needed rooms with telemetry, and so that's what we identified a place in the hospital, and we started it. And we had a paging system. So instead of activating a high-level trauma, when there was a G60 in the ER, the pager went off. And we kind of all came up with about 30 minutes. Let the trauma surgeon, you don't have to stop what you're doing, but get down there, see the patient, decide if they need CAT scans or what needs to be done, admit them, and get them out of that emergency room. We came up with order sets to make everything easy, and then we had our inclusion criteria. If you're over 60 and you have a traumatic injury, and that injury is why you're being admitted, not if you fell and have a cut here, but everything else is negative, but the ER thinks they need to be admitted for syncope workup. No, they have to, the trauma is the reason they're being admitted, and that injury occurred within 48 hours. Ding, 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 that's a G60 activation. And the trauma surgeon, so how it works, the ED sees it, activates it. The trauma surgeon has about 30 minutes to get down and see the patient, and then the trauma surgeon will call the appropriate subspecialty. And usually, for the most part, if they had any other medical conditions, we would always get the hospitalist involved, and then whoever else was involved depended on their injury. So we expedited their pre-procedural medical clearance because we kind of sat with anesthesia and we sat with everybody and said, what do we really need? I mean, are these echoes really making a difference? What are you going to change in the operating room? Help me understand why we're taking 48 hours or 3 days to clear a patient that we know has to go to the operating room. So our goals, 30 minutes from the time they present to trauma evaluation, out of the emergency room in 4 hours, into the operating room in 36 hours if they needed it, and discharge in about 5 days, safe and appropriate disposition. And again, social workers, everybody kind of gets paged, so they know that the G60 patient is in the hospital, and we start working on everything pretty much immediately. And then we had multidisciplinary rounds, and these are trauma surgeon-led multidisciplinary rounds where we sit down and everybody comes together. Again, there's the pizza again, and we talk about all the patients and what's going on. And we didn't do that every day. We started off doing that 3 days a week, and that's evolved. Now we actually 2 days a week. Now we walk around 3 days a week. And then we published the creation of the Geriatric Trauma Service. So when you do something, you have to study it and ask yourself, is it worthwhile doing this? And have you made any changes? And so we looked at our 1 year experience. So again, the majority of our patients were falls, followed by motor vehicle collisions. And this is our outcome data. Our average ED length of stay went from 6.1 to 4.2. Our average ED to getting that patient to the operating room decreased from 52 hours to about 37, 38 hours. Our ICU length of stay decreased by 2 days, and our hospital length of stay decreased. And all this was statistically significant, so we were pretty proud of ourselves. And then we looked at our morbidity, and as you can see, UTIs decreased, respiratory failure, congestive heart failure. Mortality didn't decrease. It was not statistically significant, but there was a trend toward significance. And again, our pneumonia decreased. So again, pretty proud of ourselves. And so we concluded that we thought a geriatric trauma service leads to a more streamlined hospital visit. There's a reduction in morbidity and a trend toward decrease in mortality. And we published that. And then I was recruited to John C. Lincoln. Again, I think it was kind of a trick there. There's a significant number of people who come here to retire. But John C. Lincoln, we've created a geriatric trauma service, and it's been applauded. And it's a big solution to the too many medicine admits. Every trauma center, when you go through your verification process, they look at how many patients that you admit to the medicine service, because trauma patients should be taken care of by the trauma surgeon. So if you just look in the literature now, and I just pulled up about them, and these are all 2012, okay? 2012, the aging motorcyclist, comparative study looking at the pattern and severity of injury. I have a 71-year-old in the hospital right now, John C. Lincoln, who fell riding her motorcycle. And this is just a summary of what they found, increased risk mortality rates. 2012, another article, impact of age and anticoagulation. Need for neurosurgical intervention in trauma patients with mild traumatic brain injury. Again, the age, it's a big deal. When you talk to your colleagues all across, and I ask them often, hey, pull out your trauma list. How many patients over 60? And every one of them have an increasing number. So this isn't isolated to Phoenix or Texas. This is just it's national. And that's just a summary from that article. And then a month or two ago, again, 2012 article, is fetal care in the injured elderly an important target for cost savings? So again, we're just seeing more and more of this. TQIP, the Trauma Quality Improvement Program, they too, their big things initially, and I'm sure a lot of people are involved with TQIP, or traumatic brain injury and shock. And now their third big thing that they're looking at is the elderly. And there's some observations that are being made, and that's a high-performing trauma center, so these trauma centers that are high-performing, they may not be high-performing for all types of patients, in particularly the elderly. How well do they perform when it comes to elderly trauma care? And there's a poor correlation across all age groups. So you have these centers that might be high performers for the young, but yet they're really not high performers for the elderly. So again, there's a poor correlation, and that's the key, that centers might be high performers for the young, but yet not the elderly. And I think in the next 5 or 10 years, every trauma center will be setting up some sort of protocol, finding a way to take care of the elderly that's better care than we've done in the past. And this slide just simply shows you have a high performer, 29% for our young, but not a great performer as you come across for the elderly. And it's just reiterating the same theme. And so what are some of the new things that we're doing at John C. Lincoln? Well, again, I stated that we started multidisciplinary rounds on the floor, and we go from room to room to room, a group of people, again, led by the trauma surgeon with the nurse practitioner, with the nurse who's taking care of the patient, respiratory, physical therapy, and we walk in the patient's room and you'd be amazed, wow, you guys are all here for me. They really love the attention, and we talk about their care with them in the room. We started some group sessions where around 11:30, our nurse practitioners will take those who want to come to a room, and we let them talk about their fears and their falls, and we're learning from them what they're afraid of. Well, I'm afraid of going to rehab because I don't know how long I'll be there. Sometimes some are a little demented and they just talk and we're not sure exactly what they're saying. But for the most part, we're learning from them because, again, this is new for everybody, this aging. And so they go to a room and they have their group sessions. We're starting to look at the VES, which is a vulnerable elder survey, to help us potentially predict some of the outcomes that these patients will have. And I'm giving a talk tomorrow on diabetes, and I have a strong interest in hemoglobin A1C, and so we're starting to look at that in our elderly population as well. And this is the group that rounds on the floor. Again, you can see the surgeon, nurse practitioners, RN, respiratory therapists. This is right before one of our walk-around rounds, so we walk around together, and it's a lot, and it was a big culture change. Again, this is another day. They're at the bedside. It's Dr. Ustiniano, who trained here, some of you may know, and he's leading it on this day. We do this every Monday, Wednesday, and Friday. And then our group sessions, that's our nurse practitioner, Mary, and she's actually in the audience over here, and Dr. Zandu, who's also in the audience. This day, only 2 people felt good enough to get up and come to the group session. Sometimes we have a few more. Some days nobody wants to do it. But getting them up and letting them talk and letting us learn from them. So I'll leave you with a couple of slides. Age over 65, it is growing from 2010 to 2020, all right, 38% increase. We can act like we don't want to deal with this population from a trauma standpoint, but every trauma is going to see an increase in their number of geriatric trauma patients, and you've got to figure out how we can take the best care. At the very bottom, by 2020, people over 85 is expected to reach 6.6 million, okay? Remember this, that means more trauma patients. All right, an increasing elderly population equals increasing geriatric trauma. The team again, beautiful Sedona, and I thank you for your attention.